All right. Well, welcome everyone, and apologize for a little bit of technical difficulties here at the beginning, but we're about to get started now. It's a great pleasure to introduce Roy Hamilton, our speaker for today. We've been trying to get him here for quite some time now and insisted on having him in person. Very glad that we did. Had a very nice discussions yesterday and today. Dr. Hamilton did his undergraduate work in psychology at Harvard, stayed on at Harvard for his MD degree, also got a master's at MIT, and then moved to University of Pennsylvania for his neurology residency, but in the interim did an internship here at UCLA, so this is a familiar venue to him. He has remained at University of Pennsylvania, where he is part of the Department of Neurology and has a secondary appointment in the Department of Physical Medicine and Rehabilitation. Has done a lot of really interesting work in terms of neuromodulation, but is also quite prominent in his role in diversity, equity, and inclusion at Penn, where he holds more than one administrative title, and that's in fact how I got first introduced to him in that context, but was very interested to learn of the overlaps between what we do here and what he does in terms of neuromodulation, and we're very excited to have him here to talk with us today. He's received many awards and honors, including the Norman Geschwind Award from the American Academy of Neurology, which is really a who's who of neurologists in brain mapping who have received that award in the past. So it's great to see him on that list, and very well deserved. So please welcome Dr. Roy Hamilton.
Great. Well, thank you so much. It's really a pleasure and an honor to have been invited to speak and to finally be able to make it. As you heard, I did my internship here, so this is really a homecoming for me. And in fact, I'm born and raised in Southern California, so it really is a homecoming. I was also mentioning to the people I've had discussions with that the person who eventually became my spouse was actually working in the imaging center when I was an intern in the hospital here. So it's really great to have this return to such a familiar place. For the next hour, maybe slightly less than an hour at this point, but for the next 45, 50 minutes, I am going to sort of go through what I think of as a talk that has sort of three big properties. It's going to be historical, right? Because it's going to be a march through the various efforts that we've had at the University of Pennsylvania to think about how we can use neuromodulation in the treatment of persons with aphasia of different types. So it's going to span a number of years. It's going to be apocryphal, right? Because I'm going to tell that story through a kind of simple lens and a kind of simple question, at least for a big part of the talk. That simple story in question being, well, what's happening when you have damage to the language hemisphere of the brain? What's happening in the other hemisphere, and is that useful, something that we can leverage for the purposes of trying to facilitate recovery? And then one part aspirational. So in the last part of the talk, I will talk about where I think individuals who work, and researchers, investigators who work in the field of neuromodulation for aphasia, where we ought to be going, and at least where my group plans to go moving forward. So that's the general scheme of today's talk. I do not, let's get the timing right here. I do not have any relevant financial conflicts for the purposes of this talk today. So here's another look at our roadmap for our discussion. We're going to talk about interhemispheric interactions, and we'll focus primarily on individuals who have non-fluent aphasia. So for those of you who don't think too much about aphasia, I'm talking about individuals whose principal problem is with the generation of language. Then we'll shift to talking about specific neuromodulation modalities for aphasia. I'll start by talking about our use of transcranial magnetic stimulation in post-stroke aphasia. I'll then transition to talking about transcranial direct current stimulation, a form of electrical stimulation of the brain for post-stroke aphasia and for individuals with neurodegenerative aphasias, what are collectively referred to as the primary progressive aphasias. And then at the end, like I told you, I'll talk about challenges and next steps for neuromodulation in aphasia. Because this is a varied audience, it's not clear to me how familiar you are with post-stroke aphasia, with its incidence, its prevalence, and its burden. So, neurologists in the room, please humor me for a moment while I talk about the fact that the lifetime incidence of stroke, over the lifespan, is about 1 in 6, right? So it's an incredibly prevalent, burdensome disease. What we often don't talk as much about is the fact that aphasia, the acquired loss of language ability, is the most common focal cognitive deficit associated with stroke. And depending on which reviews or summaries you read, it'll affect somewhere between 20 and say 40% of individuals with stroke. So, let's cut that in half and call it a third. I mean, that is a lot of individuals who are living with some form of residual deficit of communication as a result of this very common, very severe disorder. And so a lot of what we've thought about in our group over the years has had to do with what happens to the brain and what happens to the language system after an individual has had a stroke that engenders aphasia. And so one of the things that we see in individuals who have strokes and aphasia, well, first of all, again, step back for people who don't think about aphasia too much. I suspect that most of you are familiar with the idea that for the vast majority of individuals who are right-handed, and actually for most people who are left-handed as well, language is predominantly represented in the left hemisphere. All right, so often we are talking about left hemisphere injury. And so we know from imaging studies that if you do functional imaging, for instance, in individuals who've had post-stroke aphasia, you ask them to perform language tasks, right? Because they do at some point often recover some degree of language ability, that as they're trying to perform these tasks, they activate a different set of brain areas than healthy language users would. Right. And so what I'm representing here, this is work by Peter Tarkrotaub, who's a behavioral neurologist and a physiologist extraordinaire of his own right in Georgetown. But way back in the day, he was a fellow in our lab. So this is some work from years ago in which he employed a meta-analysis technique of functional imaging that he invented called activation likelihood estimation, or ALE. And what we're looking at here is maps of all the studies using functional imaging up until the time that this study was published, in which healthy individuals performed language tasks and individuals who had post-stroke aphasia performed those same tasks, right, in order to contrast the same sets of tasks. And what you can see, just as I was telling you a few minutes ago, individuals who are healthy language users engaged a left hemisphere set of areas that are familiar to most of us who think about language systems, or anterior and posterior areas, whereas individuals who had post-stroke aphasia, they did engage some areas of the left hemisphere. They tended to be areas that were close to regions that healthy individuals were engaging for those same language tasks. But you'll also notice that they engage regions of the right hemisphere. Right? And so one thing that is clear from the literature is that individuals with post-stroke aphasia seem to activate a different network, a different constellation of brain areas in the context of trying to perform language tasks. And so we spent some amount of time, like I told you, this is going to be a historical talk, thinking about what that role might be. And for the purposes of our discussion today, we can try to break that down, right? What that right hemisphere is doing. We can try to break that down into a couple of different broad categories, right? So one broad category is that it might be helping, right? It might be compensatory in nature. That activation might be what actually allows individuals to regain some of their language abilities if they've had aphasia. There is a different argument, and we'll walk through these different arguments. There's a different argument that says, in fact, that activation is not helpful. It's either noise or worst case scenario. It's contributing deleteriously to the performance of language tasks. Of course, it might not be as simple as either of those two things, right? Maybe there are ways in which the right hemisphere's activation is doing both. Maybe it's contributing in some ways, but maybe there are inefficiencies or certain ways in which it's dysfunctional. Of course, just to round out our set of possibilities, right? If we're gonna paint this in broad brushstrokes, you have to have the category of neither, right? Maybe it's completely spurious, maybe it's epiphenomenal, and should be ignored for the purposes of targets for intervention for rehabilitation. So let's look at each of these arguments sequentially. Okay, so first let's look at the argument as to why the right hemisphere might be helping. And for this, I'm going to really get in our time machine, go way back. Okay, so I'm going to harken back to a case from 1877. Right, this is in the British Medical Journal. This is a case that was reported by Thomas Barlow on a 10-year-old boy who suffered from infective endocarditis. Right, and so he had infection in his heart, and that infection was throwing emboli, right, to his brain and causing him to have strokes. And one of those strokes caused him to have onset of right hemisphere weakness and aphasia, signifying the fact that his left hemisphere had been affected. Here's what Barlow writes about this boy. He had lost his speech. He could only say ha ha. He could not grasp with the right hand and be dragged with the right leg when put on his feet. Now, this boy had a great recovery, as often children, right, with brain injuries do. So here's what Barlow goes on to say about it. In 10 days, he was greatly improved. The speech had returned on the 10th day, but he occasionally made a mistake, gave the wrong name for a boy, and did not seem always quite to understand what was said to him. In a month's time, he seems quite to have recovered. That's great. But the problem is that in 1877, what we didn't have was great treatments for infective endocarditis. Unfortunately, this boy had a second stroke. And when he had his second stroke, here's how Barlow describes his symptoms. The only approach he could make to a voluntary articulate sound was ah. He could cry vigorously. There was no lack of voice. From his admission, he appeared to understand all that was said to him. When asked his age, he counted 10 on the questioner's fingers, counted 4 when asked how many brothers he had, and so forth. He made signs for what he wanted, and the signs were correct. Right? So he had had a recurrence of his non-fluent aphasia, right? A recurrence of this inability to generate language, although he understood language pretty well. Well, unfortunately, as I said, no great treatments for infective endocarditis. The child passed away. And when he went to autopsy, what Barlow found was indeed he did have a left hemisphere lesions in areas of the language network that we would anticipate would cause problems with language. But he also had a second newer stroke, right, in the right hemisphere, in areas that we would think of as being in some ways homotopes, sort of mirror image areas that in the left hemisphere we would think of as being responsible for language. So the implication here is that perhaps at least for this boy who passed away, that period of recovery may have in some ways been mediated by the right hemisphere, as evidenced by the fact that when he had additional damage to the right hemisphere, he lost that recovered language ability. Right, so that's a general framework for the argument that that right hemisphere might be helpful. You can look at other cases, including WADA studies, other case studies, and imaging studies as well that suggest that the right hemisphere may have a helpful role. What about the second argument? How would you come up with the idea that the right hemisphere might be harmful, deleterious? Well, a lot of that argument actually comes from studies of interhemispheric interaction. A lot of this work having originally been done in the motor system. And the way this argument works is as follows. So if you have a unilateral lesion, one thing we understand, taking a step back, one thing we understand is that the two hemispheres are richly interconnected with one another through the corpus callosum. And if you interrogate, at least in the motor system, some of those pathways, if you stimulate on one side and you cord on the other, what you may find is that often it seems that stimulating on one side has an inhibitory effect on the other side. Okay, so the idea is that there are transcallosal inhibitory inputs from the two hemispheres on each other. Okay, so now if you have a lesion in one of the hemispheres, according to this model, what might happen is you lose the inhibition that damaged hemisphere would normally project to its intact neighbor. And so the result of that would be that the intact hemisphere has an increase in activation, but that increased activation isn't actually representative of any specific coherent activity or relevant coherent activity, but rather just a release from inhibition. Moreover, you can extend the argument even further. You could argue that when that area is disinhibited, right, when the intact hemisphere is disinhibited, it now has the capacity to send increased inhibitory projections to the left hemisphere. And one thing I didn't state explicitly, but sort of implied, is that there's relative agreement that the left hemisphere, those sort of perilesional areas I was talking about in the left hemisphere, there's relative agreement that those areas seem to be helpful for individuals as they're recovering from their aphasia. So if you make that argument, increased inhibition coming from the right to the left to those struggling little perilesional areas, right, that might actually be harmful with respect to language recovery. And there have been investigations that have imaging studies and other investigations that have suggested this argument. I put this slide in just to illustrate what I was talking about, that this is something that you can demonstrate in motor physiology. So you can demonstrate that if a person has a lesion on one side in the motor system, that if you, there's going to be an asymmetry of the motor output that you can get from those two sides, but that you can to some extent balance the output that you get from the motor system if you either facilitate or increase brain activity of the damaged side, or because of the theory I just told you, decrease activity of the intact side, right? So that's sort of the original argument for the idea that that the activation of the right hemisphere in persons with aphasia might be deleterious. So here's one example of a imaging study. There have been a few that have suggested this, but one from a number of years ago that that made this argument. And what they're showing here is that they have individuals in the scanner, obviously have chronic post-stroke aphasia, or at least it's obvious from the imaging that they have chronic stroke, and they're performing a naming task, right? And so what they're doing in this particular study is they're doing a subtraction of the instances in which the individuals are getting the names right versus when they're getting the names wrong. And to get to the bottom line, literally, if you look at where they have activation when they are naming incorrectly, that activation pattern tends to, at least in several subjects they were testing, preferentially engage the right hemisphere more than when they're naming correctly. All right, and so this author, a number of other authors, have suggested that, well, maybe that increased activation isn't actually evidence of useful coherent activity with respect to the performance of the language task. Maybe it's, if anything, it's interfering. So we got interested in this topic, again, highlighting the work from Peter Turkeltaub. I showed you the maps that he generated of all the functional imaging literature up to that point in which healthy subjects and persons with aphasia perform language tasks. That was just the first part of this particular study. So this is the other half of that particular study, in which we asked two pretty simple questions, right? And the two simple questions were, okay, and I'll focus here on the right hemisphere. If you're looking at the right hemisphere and you're looking at an area of activation in the right hemisphere in these maps, is that area of activation a homotope? And by a homotope, I mean, is it sort of a mirror image area, more or less, to an area of the left hemisphere that in individuals who are healthy language users gets activated during language tasks? Okay. And then the second question is it functionally a homolog? In other words, if you look at the patterns, because we're looking at multiple tasks across multiple papers, right? So if you look and see, is that same area of brain in the right hemisphere activated in the same instances as an area of the brain in the left hemisphere language system, right? So it's activated for task A and B, but not for C, but yes for D, but not for E and F. So if it's going to follow a pattern like that coherently, well, that at least suggests somewhat that it has some role that seems somewhat analogous to what's going on in the left hemisphere. At least it's plausible compared to the alternate scenario where the pattern of activation is completely orthogonal to what's going on in the left hemisphere, just total noise, right? Well, that suggests that it's probably not a useful contributor. Well, it turns out that all the areas we looked at were homotopic in terms of their organization relative to areas of the left hemisphere, but also almost every one was homologous in terms of its patterns of activation across tasks, with one notable exception, an area called the pars triangularis, which is it's part of Broca. Well, in the left hemisphere, we would call it Broca's area. We don't call it Broca's area in the right hemisphere. But think of it as the homotopic area of the right hemisphere of what is Broca's area in the left hemisphere. That area didn't seem to be homologous in terms of its patterns of activity across tasks. And it would be great if we could move beyond just looking at these associations across tasks and manipulate the activity of that area of brain to determine whether or not manipulation of this particular area that seems like it wasn't, at least by imaging, potentially a useful contributor to language, what that does to language performance. And, fortunately, that's what we do in our laboratory, right? So this is, I'm going to introduce the first major workhorse of our lab, which is transcranial magnetic stimulation. A lot of you are familiar with TMS, so I'm not going to give a detailed introduction. But for those of you who aren't, it involves taking a winding of coil, right, and wire. You're going to place it over the scalp. It's going to function as an electromagnet. So you're going to run an enormous amount of charge through it over a very short period of time. When that happens, you create a fluxing magnetic field. That fluxing magnetic field has the ability to generate current in things that are close by that have the capacity to have current generated in them, right? For example, neurons. And so it can generate current in underlying neurons to the point that it causes them to depolarize and fire. And because of the shape and the sort of configuration of the coils we use, I mean, we're able to achieve a pretty high level of spatial resolution in the brain, about centimeter and a half by centimeter and a half. So think about something maybe the size of your thumbnail on the surface of the cortex, which is pretty good considering that you're hitting it from the outside with a magnet. We can apply it in frequencies and intensities and rates that can either lead to excitation of brain areas or sort of functional inhibition of brain activity, depending again on the pulses and patterns. It's safe. There's a low risk if you're using it beyond accepted parameters or agreed upon parameters of inducing a seizure. But again, within widely accepted parameters, it's a very safe technology. And if it is applied repeatedly, it can be shown to have persistent effects, neuroplastic effects that we think are related to processes like long-term potentiation or long-term depression in the case of repeated inhibition. So what we did was we brought in subjects, and this is the back in the day when we're actually pretty agnostic still with respect to which brain area we ought to be stimulated. We're still thinking that maybe inhibition of the right hemisphere might be a way to go. So brought in individuals, and they had baseline MRI, baseline behavioral testing, and then they entered what we refer to as site finding. And we applied low frequency, which in this particular context is an inhibitory kind of TMS, to the right hemisphere in a variety of different spots. You see them mapped out in the different colors. And we simply looked for whether or not each individual patient, each individual person with aphasia had a best spot. By that, I mean a spot where when you inhibited the brain activity there, they had an improvement, an immediate improvement in language performance as measured by an increase in naming performance, right? And if that was the case, well, then we brought those people in, and it was a partial crossover study. So they either got sham TMS, so fake TMS, and then they were followed up for a couple of months, or they got real TMS. They were followed up 2 months and 6 months later. We did not have the heart to have those poor people in this pilot study follow all the way out to 6 months with sham TMS. So that after 2 months, they crossed over into the TMS arm. So everyone eventually got TMS. And so in this early work, what we found was that indeed that individuals had an improvement in their naming performance. So this is naming across several different categories, actions, tools, and animals. And what we could demonstrate is that the application of 1 Hertz TMS for 2 weeks, I didn't mention that. So 2 weeks of 2 5-day weeks of TMS had persistent effects on naming ability. There's a structural flaw in this graph because it was created, the figure itself was created for other purposes other than me to stand here and talk about it. And that is, it's not showing what the performance was in the sham arm. And I should tell you now, it was sort of a flat line, that nobody got better in the naming performance after having received sham in that sham phase. When we took individuals and we put them in the scanner and had them perform language tasks before and after having received TMS, before and after the treatment, well, what we found was, well, first of all, I think you can see some pretty heterogeneous results, right? Individuals activated the right hemisphere and the left hemisphere in fairly heterogeneous ways, before we even applied the TMS. But what we found was after stimulation, there were changes in patterns of brain activity. What we didn't see, I can tell you, is we did not see just uniform flattening of right hemisphere activity. It wasn't the case that the improvement, there wasn't an association between the improvement in their naming ability or other language abilities and just suppression of right hemisphere activity, making us at least somewhat suspicious of that the answer to what the right hemisphere is doing isn't probably monolithic in terms of being deleterious or inhibitory. This is other data that we gathered in these individuals. It was a change in their ability to describe this picture, what is called the cookie theft picture. And so we just elicited spontaneous speech from them, describe everything you see in this picture. And we found that individuals who had received TMS were improved in their ability to generate words of a variety of different categories, nouns, verbs, closed and open class words, or sort of different broad classes of words that I won't get into the details of, but total narrative words. Importantly, this improvement in the number of words they were able to generate when describing this picture was not because they spoke for any longer, and it wasn't because they spoke any faster, actually. So, I mean, those would be two kind of mundane reasons why one would have generated more words. It's that more of the words they spoke when they were attempting to speak words were on target, right? So, as I said, the talk's in some ways historical. We're now not the only people to have done this. So this comes from a meta-analysis we did a number of years ago using this exact method, 1 Hertz stimulation of the right hemisphere. And you can see that across a variety of studies that there was an effect that favors TMS over sham. Now, I want to go back to our site finding. Okay? Remember, I mentioned that for each subject in our study, we took the coil and we searched around for the spot that was the best site for that individual subject. And we were pretty agnostic about which site we would target, which site we would stimulate, depending on what we found. But what we did find was that for the vast majority of subjects, it was the same spot, right? It was either that green spot for most people or that blue spot. What I'm showing here is the average change in naming immediately after the application of TMS across the subject cohort, right? And you can see that for most individuals, it's pretty much this gyrus right here. Well, what is that? It turns out that is the pars triangularis of the right hemisphere in the inferior frontal gyrus. And if that name sounds familiar, it's because that's the spot that we identified in our prior meta-analysis of all the functional imaging literature as the spot that didn't seem to be meaningfully contributing, or at least it didn't seem to be a homologue with respect to its patterns of activity across language tasks. So, we hypothesized that maybe what we had stumbled on was a kind of noisy node whereas other areas of the right hemisphere may be contributing usefully, maybe that particular site isn't, and that suppression of that particular site in our study was having a beneficial effect in our patients. Now, that in and of itself doesn't make the argument, doesn't sort of lock down the argument that the right hemisphere, the other areas of the right hemisphere are helpful, right? Maybe the pars triangularis is just the worst actor, and all the other brain areas are nonetheless also bad actors, right? That brain activity is either, the rest of the brain activity is either unuseful or deleterious. Well, it turns out that we had a case that I think helped us at least put the nails in the coffin of the idea that the right hemisphere is monolithic in terms of being deleterious with respect to language recovery. And so this was one of the cases from our study in which we applied inhibitory stimulation of the right hemisphere. Like practically every other subject in our work, this person demonstrated their best effect from inhibition of the inferior frontal gyrus on the right. So what I'm showing you is bold fMRI showing a decrease in functional activation. This is just to show that we're decreasing the functional activation of that pars triangularis on the right. Unfortunately, however, this patient, after showing a pretty good response, had a second stroke, and so that's what I'm showing you here. The second row of images are diffusion weighted images, so that looks for acute stroke. And so this person, you can see those bright white spots. That's her second stroke, and it's a subcortical stroke, right? It's mostly affecting white matter as opposed to her relatively sizable prior left hemisphere stroke, and that's obviously it's not good to have more strokes. But if you were a hardline interhemispheric inhibition devotee, you might say, well, okay, generally her cognition might not be faring as well as a function of having had a stroke, but perhaps if the right hemisphere's inhibition of the left hemisphere is harmful for left hemisphere recovery and overall not helpful for and right hemisphere activity is not helpful for language recovery, maybe disconnecting that right hemisphere a little bit through the white matter tracts, like maybe paradoxically that might be helpful or useful for individuals who are trying to recover from aphasia. Well, it turns out the answer is just the opposite. So this patient, who we are very grateful to for allowing us to continue testing, she demonstrated, a decrement in some abilities after her second stroke, but the most prominent decrements were in her language ability. So what's represented there at the bottom of the graph is her performance on naming and a general performance of language on a battery that tests multiple domains of cognition, right? A disproportionate loss of language. In some ways, akin to what we saw in Barlow's 1877 case. And so in our minds, that, again, as I said, put the nail in the coffin, the idea that the right hemisphere is monolithically deleterious with respect to its contribution to language and recovery in persons with aphasia. Now, everything I've been saying thus far, it turns out that it might be more applicable to individuals who have non-fluent aphasias than fluent aphasias, where their problem is more in the comprehension of language. So the thing that makes me say that is that recent evidence from a group in Germany headed by Dorothy Sauer and a number of others, they are expert in imaging individuals serially after acute stroke until they get to the chronic stroke phase, looking at patterns of brain activation that result from stroke. And what they demonstrated relatively recently was that you get different patterns of activation and reactivation depending on whether the stroke is more anterior or more posterior, where individuals with more posterior strokes, I'll focus there first, that they don't seem to get a lot of engagement of areas that we think of as the lesion homologs, sort of opposite side of the brain lesions, or sorry, opposite sides of the brain regions that as the area where they had the brain injury, right? As opposed to activation of homologs, which you see robustly in individuals who have more anterior lesions, right? And so there's reason to suspect that a lot of the work we've been doing, since we focused on individuals who had non-fluent aphasia, that it might be more applicable to that patient population. All right, so let me give you an interim summary, right? And so just to put it a little glibly, like this is basically 5 years of work summarized in 4 words. All right. And let's return to our possibilities when we're talking about what could be going on in the right hemisphere. Do we think it is entirely helpful? Well, no, probably not, because if that were the case, then administering inhibitory transcranial magnetic stimulation over and over again to a particular site in the right hemisphere wouldn't have both temporary beneficial effects and enduring beneficial effects. Oh, sorry. First of all, do we think it's doing nothing? We'll just take that one off the table. All right. So then, do we think it's helpful? Not entirely, for the reasons I just stated. Do we think it's entirely harmful? Well, no, because if that were the case, then again, you wouldn't expect to see these cases repeatedly through history and in our own lab, where individuals who have right hemisphere injury have preferential decrements of their language ability after some degree of recovery or some degree of improvement. So, we think our story is much more complicated. And, as I'll return to at the end of the talk, a lot of what we're interested in moving forward in the future is how we try to differentiate what's going on in these areas that are activated, how we tell the wheat from the chaff, so to speak. All right, so now we're going to abruptly shift gears. We spent almost all of this time talking about transcranial magnetic stimulation. We're going to spend a little time talking about transcranial direct current stimulation, the other main workhorse of our laboratory. A lot of people out there in cyberspace and in the room have some degree of familiarity with transcranial direct current stimulation, but let me give you the thumbnail sketch for those of you who haven't heard of it. So as opposed to TMS, which is capable of acutely, right at the moment of discharge, causing neurons to fire because it can depolarize them. tDCS is subthreshold, right? What it does is it nudges millions of neurons a little bit closer, a little bit farther away from their action potential firing thresholds. And that effect of which is to alter their firing rates over large assemblies of neurons. It can be applied in different ways. You can put either the cathode over the brain or the anode, think of it as sort of plus and minus signs. And there's some evidence that that different application of different polarity electrodes has different effects on brain activity. If TMS was safe, tDCS is very safe. In the history of the device, there are no reported instances of serious adverse effects. It's also quite inexpensive. It combines nicely with other therapies because you can wear it on your head and sort of move the head about while you're doing things like speech therapy, physical therapy, those kinds of things. And like TMS, we think that giving it repeatedly has enduring effects on plasticity that are akin to long-term potentiation or long-term depression. All right, one of its putative downsides, at least for conventional transcranial tDCS, is that it has pretty low spatial resolution, right? So if you map the current flow, if you're giving a conventional stimulation montage, with these large sponge electrodes, pads that you're sticking on the head, you get this smear of current that just runs through all the spaces in between those two electrodes. Now that if you are a cognitive neuroscientist and you are trying to differentiate, very small amounts of anatomy, right, very, very specific anatomic circuits in order to elucidate structure-function relationships, that's sort of a bug. But if you are trying to increase activity, and this is another representation, slightly different looking, but it's another representation of Peter Turkeltaub's data. If you're trying to increase activity in a bilateral network of brain areas, well, maybe you do want a relatively diffuse technology. So we applied tDCS in individuals with chronic post-stroke aphasia. You'll recognize the study setup. It's very similar to our TMS study. And what we found was that, in this case, our time course is a little shorter. At 2 weeks and 2 months after stimulation, where the stimulation period was for 2 weeks, 2 5-day weeks, individuals with chronic aphasia had a significant improvement in their aphasia severity. This is as measured by what's called the Western Aphasia Battery Aphasia Quotient, or WAB-AQ, right? And so what you can see there is that they had persistent and significant changes. And this time I am showing you the sham data. So you can see the individuals in the sham arm had no change with respect to their language performance. All right, again, a historical talk. So we're not the only people who've done this now. And so this is from one of our meta-analyses of this topic, and can demonstrate again that across a wide literature that there's been demonstrated effects that favor tDCS over sham for individuals with aphasia. One thing I'll point out here is what I'm showing you in the center of the figure is where people have applied the electrodes. And I think that this speaks to the relatively diffuse nature of stimulation, right? That they're playing the electrodes here with conventional tDCS every which way but loose, and demonstrating across the studies that they can generate effects. Again, probably stimulating a bilateral network of brain areas. I would be remiss if I didn't mention what's probably to date the largest study having to do with tDCS in persons with post-stroke aphasia. That's from Julius Friedrichsen, who looked at 74 individuals and found that individuals who received anodal tDCS had a better response in individuals who received sham tDCS. They published this in a series of studies, initially demonstrating a failure of futility. So they initially failed to demonstrate that it doesn't have an effect, and then they published that a significant effect, a significant positive effect. So we've also gotten interested in applying this to individuals with neurodegenerative aphasias. And so what I'm showing you here is a map of patterns of atrophy in individuals who have 3 different identified primary progressive aphasia syndromes. We won't go into the details of the different syndromes. Suffice it to say, there's one that's more anterior. That's what's represented by the atrophy in the red there. And as you might anticipate, those individuals are more non-fluent. There are a couple more posterior ones. There's one in the temporal lobe where individuals have problems with semantics, and where you see the atrophy in purple there, those individuals have what's called logopenic progressive aphasia. It's often associated with word finding problems and repetition problems, and often the underlying pathology in logopenic aphasia in about 90% of individuals turns out to be underlying Alzheimer's pathology. All right, so we've been applying tDCS in these patient populations. They are not as common a presentation as you might imagine some other neurodegenerative disorders, like amnestic patterns in individuals with Alzheimer's disease. So we tried to be quite inclusive with respect to where we applied our electrodes, so that we could try to use a stimulation pattern that would capture areas of atrophy in all 3 aphasia subtypes. Again, a very familiar protocol for people by now. We had 10 days of stimulation using tDCS, measured performance 6 weeks and 12 weeks out. We had an initial open label study, which demonstrated pretty positive effects in speech production, repetition, grammatical comprehension, semantic processing. We followed that up with a small sham-controlled pilot and demonstrated that there were improvements in a variety of different language production areas. I'm showing just one of those, which is fluency. And one interesting thing that we did find once we introduced a sham arm and started looking at who was a responder and who wasn't, was that that it tended to be the case that individuals who were more impaired at baseline had a better response to tDCS than individuals who were less impaired at baseline. Now, for you statisticians in the audience, you might say to yourself, well, but Dr. Hamilton, boy, isn't that just like regression to the mean? Right? And the people who start off worse, you test them again, and then like maybe they'll be better. Let me say, perhaps, but it's important to note that in the world of aphasia, your severely impaired patients typically don't show, they're the ones who don't respond to anything, right? Don't respond to interventions. And so, in our hands, and this has actually been replicated across a few studies, and not just by us, the idea that you could have some form of stimulation that might be more effective in the people who are more affected is actually pretty encouraging. All right, again, would be remiss if I did not mention a colleague and friend who has performed in subsequent years what is now the largest tDCS clinical trial in individuals with primary progressive aphasia. It's Kiran Sapkini at Johns Hopkins, this time looking at 36 randomized patients, demonstrating that individuals had improvement in a variety of different language areas. Interestingly, and in parallel with our own findings, she found that the benefits were more noticeable or more profound in individuals with non-fluent aphasias, that anterior type I showed you, and in the more posterior type, the kind that was associated with Alzheimer's pathology, the logopenic type, but less so in individuals who had that semantic variant that primarily affects the temporal lobe. So in the last few minutes, I've given you what I think of as a kind of whirlwind tour of the entire history of our lab in terms of what we've been interested in with respect to neuromodulation and aphasia. So what I want to do the last few minutes is talk about where we want to go next and why. And the way I want to frame that is by talking about what insights I think we've achieved, where I think there are still knowledge gaps, and then what the steps would be to address that. So first, I think we and others have generated numerous encouraging proof of concept studies, right? I think there's too much signal there to say that there's nothing there, right? So the problem is that there's still insufficient clinical data to justify widespread use. And to me, the solution to that's pretty straightforward. You need larger randomized controlled studies. Also, I think to date, the interhemispheric inhibition model has been a useful framework. There's this saying, I think an economist said it once, right? All models are wrong, but some are useful. Well, I think interhemispheric inhibition was useful, but this model is way too simple to guide the future of neuromodulation with respect to language recovery and looking for sites that are going to be responsive to neuromodulation. So we need novel tools and models to characterize language system plasticity. Specific approaches seem effective, right? We've had some success with 1 Hertz repetitive TMS or an inhibitory form of TMS, but actually there's a paucity of knowledge about whether or not other sites or other parameters might be useful. So we need novel mechanistically informed sites and stimulation parameters. And then finally, it turns out that everyone didn't respond the same to stimulation, and individual responses to neuromodulation vary widely, but we don't really have a good handle on the factors that predict response to neuromodulation. So we need to explore predictive patient features and intermediate markers of plasticity. So let's get into each of these. As far as bigger trials, I mean, that's on the way. So I'm just highlighting the fact that in our lab, we're much of the way through, hampered slightly by the pandemic, but we're much of the way through a phase 2 clinical trial of TMS and post-stroke aphasia, applying TMS again to that pars triangularis in a much larger sample of individuals to see if we can replicate and extend the work that we've done. Also pairing it with a variety of different imaging modalities. We are also engaged in several studies using tDCS in primary progressive aphasia, including conventional studies with tDCS, large pad electrodes. We have a study involving what's called high definition tDCS, so smaller electrodes that are targeting a more specific area, in this case, the left frontal lobe, in order to see whether or not that has a preferential effect. And then more recently, very recently, we were just approved to have what is going to be, I'm pretty sure, the largest tDCS trial of PPA to date, very certainly, in fact, between 3 sites, ourselves, Johns Hopkins, I showed you data from Kiran Sapkini's lab, and Howard Charkow at Baycrest in Canada. With respect to factors that predict response to stimulation, I already alluded to this once. We and actually a number of other investigators in TMS and tDCS for post-stroke aphasia and in tDCS in primary progressive aphasia have shown that your baseline impairments matter. I talked a little bit about baseline impairments and severity making a difference. That's been demonstrated in other groups as well, as I said. But also what kind of deficit you have in your language seems to make a difference. So for example, in a separate study, we brought in individuals with chronic post-stroke aphasia. We applied a different form, don't get hung up on this, a different form of inhibitory stimulation called continuous theta burst stimulation. Just think of it as a very robust inhibitory form of stimulation. And what we demonstrated was that we could reproduce an improvement, an immediate improvement in naming ability in these individuals, in particular for words that were kind of liminal for them. They didn't always get them right, didn't always get them wrong. At baseline, they sometimes got them right or wrong. We could sort of nudge them in one direction. That only seemed to matter for phonological errors. Just to take a step back, talk about the kinds of mistakes you can make when you have aphasia, right? Sometimes you make mistakes with respect to the word sounds you actually generate, phonological errors. Sometimes you make mistakes with respect to the meanings of the words that you are generating. And it's not uncommon to have both kinds of errors when you have a problem with the production of your language. Well, it turned out that most of the impact of stimulation seemed to be with respect to phonological errors, and the degree of phonological errors that they had at baseline was predictive of their response. So we're starting to hone in on what seems to matter when we are applying TMS in individuals with chronic post-stroke aphasia, at least in this one site that we are very accustomed to stimulating. So let's think for a moment about factors that predict response. Amongst the factors that predict response, differences in the plasticity of the brain itself, okay? And so this is work that we did over a few years. We were interested in whether or not we could, initially, whether or not we could use a particular kind of brain stimulation as a kind of marker for brain plasticity. I mentioned it already, something called continuous theta burst stimulation. Again, I don't want to go into details of how it's done, but think of it as a sort of a brief but pretty robust inhibitory form of stimulation. And so what we were interested in was we measured cortical excitability. And one way you can do that is by stimulating over the motor cortex and seeing what kind of response you get out, something called a motor evoked potential. Okay. And then we would take continuous theta burst stimulation, put it over the motor cortex and suppress the motor cortex, and then measure the motor evoked potential again. All right, so we're measuring excitability, we're pushing down the excitability of the cortex, and then we're measuring excitability again. And so the hypothesis at the time was that after you do this run of continuous theta burst stimulation, the extent and degree to which you had persistent depression of brain activity was a kind of marker, a kind of measure of how mutable, right, how plastic your brain was. Right? And we wondered whether or not that would have some impact on things like, well, overall recovery, aphasia severity, response to neuromodulation. For people who've never heard of this approach before, I liken it to memory foam. Okay, you know, the memory foam in beds, you push it down and it sort of springs back up. Well, if the foam is really hard and it's not very plastic, right? Like you push your hand down and it sort of comes right back up. That tells you something that it has a sort of different kind of consistency, a different kind of responsiveness than if you sort of press it down and it stays down and takes a while to come back up. And that's the sort of basic concept we're working with, right? That the mutability of brain activity is as a marker of its plasticity. And so what we found in a series of studies, so the first thing, one of the first things we discovered was that one of the biggest contributors, because we measured other features that we knew were going to be contributory in one way or another to brain plasticity based on the literature. And so one of those features that we looked at was the genotype that people had for BDNF, brain-derived neurotrophic factor. It's a factor that's been implicated in learning, memory, a wide range of neuroplasticity functions. And so one of the first things we picked up on was that in fact, you got very different signal out of the brain depending on what our subject's genotype was for BDNF. That individuals who had the they were VAL MET carriers, which is about 27%, give or take, of the population. You know, they had first of all, a lesser response when we were initially just trying to get MEPs out of them, but also a different response to this theta burst stimulation. So what I'm showing you here is the response of individuals who are VAL-VAL, okay? So that is the more common genotype. And you can see that they, after you apply this theta burst stimulation, they have a suppression of their brain activity as you would expect. And then it kind of comes, well, it actually stays suppressed for the entirety of 30 minutes, which is not uncommon for theta burst stimulation. Individuals with VAL MET, they do not have that suppression, at least not within the first 20 minutes or so. They might have a delayed response. And, you know, I think in a future study, we might follow this out even longer. But one thing is clear, they respond quite differently. Well, we then did that same index, we did that same measure in individuals with post-stroke aphasia. Remember, they have at least one intact motor hemisphere, right? So we're applying theta burst stimulation over their intact hemisphere and demonstrating that, in fact, two things, that if you built a model of stroke recovery, including things like lesion size, lesion location, age of the patient, all these other features, a model that includes the information you got about their BDNF genotype status, right, actually adds accuracy to whether or not, to how well those individuals recovered, to how well the model predicted recovery, okay? Moreover, if you just looked at the individuals who were VAL MET, the less common genotype, what you then found is that in that population, the theta burst measure itself, right? Whether or not you had this index of how suppressible brain activity, how mutable the brain activity was, that also added information to the model, gave you predictive value as to how people were going to do in terms of their stroke recovery. So now we're using TMS in a very different way, right? We're using TMS and other measures of plasticity as predictors of recovery and of predictors of response to stimulation. Okay. Last gear shift, completely different direction that we're last thing to talk about. And that is trying to figure out, using imaging, which areas of the brain we ought to be stimulating. I mean, I showed you how we found that pars triangularis. I mean, we basically were agnostic and stumbled across it, right? And so that can't be the best way to identify which areas of the brain ought to be stimulated in, say, the right hemisphere or perilesional areas of the brain in persons with stroke. So this is work that I've been doing with John Medaglia, a faculty member at Drexel who trained in our lab. He's an expert in network neuroimaging, looking at anatomic imaging, where, the basic intuition is that cognitive localization in the brain is obviously a function of its local and global connectivity. And so we are interested in and have been using something called network control theory. And so the idea is that you can look at the properties of different nodes in a network and make inferences about their role in a network, like what they do in a network based on their connectivity. So for example, you might imagine that this node that's very connected in this particular little module has a very different role than this node, which the job of which, if you had to sort of anthropomorphize it, is to connect and disconnect these large modules, whereas this node here, right, has a limited and very specific purpose. The only thing it does is act on that, right? And so you can sort of develop different properties or have different names for the different properties that these nodes may have. And sorry, I'm stuck again there. So that's what I'm talking about network control theory that allows inferences about the operational utility of brain centers based on anatomic connections. And so we've been doing this in individuals, first in healthy individuals, because we explore the healthy language system first to see if this has any purchase. And so we broke the brain down into networks. And then again, I'm just using this cartoon to illustrate a couple of properties that we're interested in. One is boundary controllability, the ability to integrate and segregate these large modules. So this would be an example of a node with high boundary controllability, as opposed to modal controllability, which is the ability to get the brain into very, very specific, hard to achieve states, which, for example, this node has only one job, which is to increase the excitability of that node specifically, which is hard to achieve in any other way. All right, so what we thought was, and this is work with healthy individuals, that if you look at regions of the language network, like Broca's area, that the degree to which you have these different properties in Broca's area might be predictive of how well you perform certain tasks or the degree to which those brain areas participate in certain tasks. In particular, we thought that having the ability to integrate and segregate large modules of the brain or large networks might have something to do with your ability to perform open-ended tasks. I ask you a language question and there are just a bunch of different answers you could generate, right? Maybe that property of connectivity is important. Whereas maybe in the situation where there are only very, very specific answers that must be generated, there's only one answer, right? Maybe you need more modal controllability in those closed kinds of language tasks. And indeed, that's what we found. In the interest of time, I'm going to sort of blow right through the specifics of the table of the graphs. But what we found was that indeed, if healthy individuals with intact language systems had if they had high boundary control in Broca's area, then inhibiting that area with TMS would perturb their performance on open tasks. Whereas if you had high modal control in that brain area, if you were that individual, and remember, these are all intact individuals, they just vary with respect to these network properties, right? That your performance on the closed tasks would vary depending on the application of TMS. So the point is that individual network anatomy can now be used to predict the effect of TMS on a language task, right? And so we start to think about applying this to stroke populations and with aphasia, and this is going to be the last slide. So this work is still still being prepared. So in a paper that is not yet released into the wild, what we've recently demonstrated is a couple of things. That individuals with post-stroke aphasia, if you look at their boundary controllability in the homologue of Broca's area, in that pars triangularis, their boundary controllability is significantly higher than an analogous group of healthy language users, right? So it seems to do something different with respect to its network role. Moreover, it turns out that if you look at the phonological errors that these individuals are making, their phonological, but not their semantic errors, seem to co-vary with their boundary control, okay, in that brain area. And I want to hearken you back to data I showed you before, which suggested that those are the errors that we are correcting when we suppress activity of that brain area using TMS. All right. And so now we're trying to close the loop, right, to see whether or not we can use network properties to identify what properties will change, right, in individuals who have post-stroke aphasia and which properties we can manipulate with TMS. And that's the sort of work that we're going to be doing moving forward. So to conclude, I hope I've convinced you that aphasia engages a biohemispheric post-stroke language network, that focal manipulation of the right inferior frontal gyrus with TMS enhances language performance, that diffuse direct current stimulation may facilitate recovery in both post-stroke aphasia and primary progressive aphasia, and that bigger studies, novel imaging tools, and better predictors of treatment response are on the horizon for neuromodulation and aphasia. And with that, I thank you for your time and attention. I'd love to take any questions anyone can stay around for.
Thanks, Roy. It was very inspirational and a very clear talk. I think we do have the room for a few more minutes at least. So if there are questions or questions on Zoom, maybe you can repeat any questions.
Sure. Let me just make sure that I don't ignore the chat. Okay.
Thank you for that very nice talk. I wanted to ask about the direct current and diffuse stimulation work. You do that sort of offline when they're not engaged in any particular task, right? Just some number of minutes, and they do it every day for.
No, actually, and that's a great question. I'm sorry. Did you have a different question, or can I speak to that?
My question is going to be how much do you think it matters what they're doing while they get the stimulation, and do you ever try manipulating that, because the tDCS is sort of enhancing processing that would already be happening. It's not creating sort of firing of the neurons.
Yes, there are varying opinions about this, but I am of the opinion that just on the basis of how we think tDCS works, it should be the case that that you would get more effect if you had some relevant behavior that you were engaged in during stimulation. Because remember, I said that tDCS is a sub-threshold stimulation technology, right? It doesn't actually cause the neurons to fire right then and there. So if you want to maximize your effect, and also if you want to make your effect more specific, the rational choice, at least from my perspective, there are those who disagree. So, but would be to engage them in behavior that selects out the circuit of interest. So in our case, the language network. So we actually engage our subjects, and this we didn't in our earliest work, but now we definitely do engage our subjects in speech language therapy, or at least a speech language therapy like intervention at the time that they're getting stimulation, because we want to co-activate the language circuit while they're getting this additional nudge from stimulation.
Okay. Yeah. So, but it would take too many subjects to be able to have a condition where they're getting it while they're just sitting there in the waiting room, or even like they're sleeping. I mean, we don't know yet how important it is, but we suspect that that's a relevant factor.
Yes, you're correct. And you also point to an important problem with the literature, which is that investigators are very rarely incented to both investigate, whether individuals are performing a task and not performing, to have all those arms in a treatment study. I will say this, that we did do a study a number of years ago in healthy individuals, in which what we did was we applied stimulation and we had a cognitive task, and we could dial up or down the difficulty of the cognitive task with respect to what we were testing, which is working memory. And we found that, you could apply the stimulation and have people do, it's not nothing, but next to nothing, because the task was really easy. And then they would perform a different task, and it wouldn't affect their performance on the task, right? But then if we dialed up the difficulty where they were actually using that cognitive domain and applied stimulation, well, then they had a response in this other task that tested the same domain. And there was no response in either arm to the sham, right? So we believe that what you do during stimulation matters.
Thank you, Dr. Hamilton. It was a great talk. I'm wondering, you touched on this very, very casually in the middle of the talk, but in the stroke recovery field, in the motor circuit,
Currently, the biomarkers are really, really relevant to understand the trajectories of recovery. So right now, we're studying as part of the Verify study, a bedside measure of finger extension through the SAFE score, association with motor evoked potentials. And we touched on this briefly when we commented on phone inhibitors. Are there bedside markers and or circuit level markers that can be used to predict recovery in aphasia?
Yeah, so
Can you repeat the question, please?
yeah, so the heart of the question is whether or not there are bedside measures that could be paired with neuromodulation as predictors of recovery from aphasia. It's a great question, and you're using as your jumping off point the Verify study, which hopefully Penn will be engaged in soon as well as a collaborating site, in which we're using these motor measures and motor physiology measures as potential markers for recovery of motor function in individuals with stroke. So the question is whether there's something parallel you could do with aphasia. And, the answer is, at the top level answer is, I don't know. But if thinking about what's challenging about that for a moment, you don't have the same kind of transparent physiologic readouts that you do, right, with the motor system that you do with in language performance, right, which makes it challenging. Now, you could start to speculate about them for what could be useful. For example, it is possible, for instance, to generate evoked potentials from TMS that are dissociated, sort of EEG-based evoked potentials that are dissociated from motor physiology. So it's physiologic measures of stimulation, more or less at any site in the brain. Or, you can imagine other measures that invoke or that use other imaging modalities, although some of them would be hard to employ at the bedside, right? Because your question was about bedside measures. So I don't think it's impossible. I just think that it's historically been challenging because you don't have that same kind of easy access to a physiologic measure that you can measure on a trial by trial basis so quantitatively as you can with sort of motor measures like evoked potentials and related physiologic measures. But an interesting challenge to try and tackle.
Zoom questions.
Yes. Do you think that in people who are left hemisphere dominant for language, that the right pars triangularis inhibits the undamaged area in the left hemisphere, or that inhibits helpful right hemisphere areas? People who are left hemisphere dominant for language. So I don't know if the person is asking about persons who are intact, or if they're asking about persons who have aphasia. I think that we spent much of the time talking about persons who have post-stroke aphasia. And so, I think that the answer there is that in people with aphasia. Okay, so thank you for clarifying. So I do think that for individuals who are left hemisphere dominant, that the right pars triangularis, I don't know if what we would describe, what it's doing should automatically be thought of as being inhibitory. And that's one of the questions that we want to sort out. In other words, it's not clear to me that this paradigm of interhemispheric inhibition needs to be adhered to. In other words, this idea of a kind of seesaw, that if you're inhibiting one, that the other's getting more active, or if one is active, then the other's getting less active. It seems to me like there are many more ways in which you can imagine that a network is being manipulated, and that manipulation of nodes within a network are having net effects on that network than just a sort of straightforward connection, disconnection, sort of up, down, push, pull. And so I part of what we're trying to do with the work we're doing with John Medallion, the anatomical imaging and the network imaging is to try and figure out if there's something a little more nuanced than just a sort of straightforward push-pull between brain areas. Even though we have repeatedly demonstrated that suppressing brain activity in that area seems to be beneficial with respect to language performance. And to your second question, it may be so actually my answer to the first part of the question also informs my answer to the second part, which it might be more complicated such that there might be interactions with other areas in the right hemisphere, right? There's some evidence that there are some interactions, say, for example, between different areas of the inferior frontal gyrus, right, when you're applying stimulation, that there's connectivity between, say, the pars triangularis and the pars opercularis, which is like right next door, right? And so there might be other connections, including within hemisphere connections, that are relevant to how the perturbation of right inferior frontal gyrus activity is leading to improved performance. Great, thanks.
All right, we'll wrap up. Thanks very much again.
Of course, my pleasure. All right, thanks, everyone.